Morning, everybody. Dr. Gillard here once again. It is Tuesday, and we are finishing off. We usually do endocrinology on Mondays and Tuesdays, so this is kind of part 2 of endocrinology. Then we'll get into GIGU. When does that start on? God, every day, right? Tomorrow, I think. No, I don't think tomorrow. Anyway. Here we go. So we were talking about, what were we talking about? Adrenal insufficiency. Let me get this on. Well, we said there's 2 types of adrenal insufficiency, right? There's a primary adrenal insufficiency. Who is that? What's the AKA? That's Addison's disease, right? Addison's disease. And what's the number one cause of that? Autoimmune attack against 21 hydroxylase. Right? We said that's the main culprit there. And if that's true, who gets taken out? 21 hydroxylase makes aldosterone and it makes cortisol. So both of those gets taken out. Does DHEA get taken out? No, it doesn't get taken out. In primary adrenal insufficiency, can DHEA ever be taken out? Yes, there are other types. In fact, tuberculosis, number one cause worldwide, at least according to one author. That will take out everything. The zona glomerulosa, zona fasciculata, and zona reticularis. And there goes all of your 3 main hormones, right? Or adrenal steroids are all taken out. Now, what's the deal with secondary adrenal insufficiency? The problem is with who? No, not the adrenal gland, with the HP axis. So there's a problem usually in the hypothalamus or in the pituitary itself. Bottom line, who does not get secreted? Who does not get secreted? Good. ADH? No, that's ridiculous. Adrenal corticotropic hormone, ACTH, is not secreted. Right? No. Okay. So that's kind of a review of those guys. What's the number one cause of secondary adrenal insufficiency? Autoimmune attack against the paraventricular nuclei? Dr. Gillard, you're being silly. No. What is it? It's man-made. It's an iatrogenic problem is the number one cause. It's the prolonged use of the medications like prednisone for the treatment of chronic lung disease or chronic rheumatoid arthritis, musculoskeletal disease, GI problems, skin problems. The baby boomers are using that stuff up like crazy. And we learned that after stopping, because the adrenal gland atrophies after taking something like prednisone, right, which is a corticosteroid. The trouble is when you stop taking it, your adrenal gland may take years to come back to function. It may never come back to function. I think, 16% in that new study I presented? So yeah, that's a definite problem. All right, so there's our little review. Clinical findings in general, it's really hard to tell exactly what's going on with these patients. It can ramp up, though, to be a life-threatening, especially Addison's disease. Or primary adrenal insufficiency can kill you. It can be life-threatening. Right? We said here's the symptoms with this. So weakness, tiredness, fatigue, anxiety, weight loss. I mean, there's a million things that could be. Could be depression has this. hypothyroidism. There's all sorts of things. But then we add this one in here. 94% of Addison's patients are primary adrenal insufficiency patients. That's a big number. They have patches, right? They start getting pigmentation. I mean, they don't look like this, but they start getting patchy skin, right? It could be like a nice tan, but usually it's more patchy. And especially we'll learn in the mucosal membranes. You can look in there and you can see the pigmentation as well. What's that from? Well, and that's only in primary, right? And not in secondary? Yeah, what's that from? What happens? What blood molecule is very high in patients with Addison's disease? Cortisol? No way. Aldosterone? No way, unless their R2A system is turned on. Is that true? No, it's broken. ACTH. Yeah, because there's nothing wrong. In primary adrenal insufficiency, there's nothing wrong with the HP axis. What does that mean, HP axis? Hypothalamus, anterior pituitary, that stuff is all fine. The problem is with the adrenal gland itself not being able to make cortisol or aldosterone. All right. All right. So gastrointestinal symptoms, very common. Hypotension, tachycardia. All right, we'll talk about more of this stuff. Hyponatremia, hyperkalemia. What about blood work in someone with primary adrenal? Oh, did we even finish? I don't think I finished. What causes this? I don't think I finished that. So in primary, the adrenal gland, nothing's wrong, or the HP axis, there's nothing wrong with it. So it cranks out ACTH like crazy. So you're going to have high levels of ACTH in primary adrenal insufficiency. And the ACTH gets into the skin, and it turns on alpha MSH, right? Alpha MSH. And alpha MSH stimulates melanocytes to start making extra pigment. Did we talk about that? If not, I think there's more slides in here today, but that's the story with that. But, all right. What about blood work? So people with primary, they will have low levels of cortisol and aldosterone, and they'll have high levels of ACTH, just like I said. Not enough cortisol around. Remember we talked about the double negative feedback system, where this goes up and knocks out the HP axis, right? Cortisol operates on a double negative feedback system. But there's no cortisol around, so there's nobody to turn off ACTH. Right? Patient with secondary adrenal insufficiency, what will they have? Well, they'll also have low levels of cortisol, of course, but they'll also have, the key with them is, they'll have low levels of ACTH, and they will not have that hyperpigmentation, right? Because you have to have high levels of ACTH to create the MSH, alpha MSH molecules. Good? All right. How does someone usually find out that they have Addison's disease? They can go years and everything's okay. Maybe they don't have the greatest energy. But then they have some big event. They fracture their femur. They get really sick. Maybe they get COVID-19 and have a high fever. That is going to cause a problem in the body. A huge stress like that soaks up your blood glucose and your glycogen levels like crazy. And therefore, you have to make more without eating or drinking. Who does that? Cortisol does that, amongst many other things. That's one of its main functions, is to maintain blood glucose levels. If you have adrenal insufficiency, primary, even secondary, you can't make cortisol, so you can't respond to that major stress event. And therefore, if your blood glucose sugars go down and down and down, you suffer a progressive hypoglycemia, and you could slip into hypoglycemic shock and you can die from this. So very, very serious problem. Okay, let's see, blood loss or dehydration. So if the major stressful event, so what else can stimulate this adrenal crisis or acute adrenal crisis? So it's not just the stress of breaking your femur. If you become dehydrated and the R2A system needs to fix that problem, maybe you have a gastrointestinal bug and you have diarrhea. Normally aldosterone would be kicked on like crazy to try to absorb water from the filtrate. But that doesn't happen because you can't make aldosterone. So any type of blood loss in combination with that trauma or dehydration, that will also, in addition to hypoglycemia from not having cortisol, now you have hypoaldosteronism and its sequelae, which is if you don't have aldosterone around, you can't uptake salt and water. So you have hyponatremia. Your blood doesn't have enough salt in it. You also have hypovolemia, which is basically low blood pressure. You're not reabsorbing water on top of the dehydration. So your blood pressure and your blood volume is low. But don't forget, aldosterone also kicks things out in exchange for salt and water. It kicks potassium out, right? So you have, if you can't kick potassium out of the bloodstream, you have hyperkalemia, which is very dangerous. It could cause ventricular fibrillation and kill you. And then we can also have, because it normally kicks out hydrogen ion, it's not going to do that either. So you get a buildup of hydrogen ion in the blood, and that is metabolic acidosis and all its sequelae. And you won't go down that road because I'm sure you've had that in physiology, right? So those are signs, other signs of acute adrenal crisis. So, I mean, most of the time they come into the ER, they have all of these things going on. They're really sick. What do these conditions, or why do these conditions occur in aldosteronism? Well, because, as I just said a second ago, the R2A system can't stimulate the release of aldosterone. There's nothing wrong with the kidney or the R2A system. It still makes renin, right? And renin's ultimately converted into angiotensin 2. But angiotensin 2 hits the adrenal gland and nothing happens. So that's the problem. No aldosterone, no salt and water, no expulsion of hydrogen ion, potassium. Now this phenomenon would not occur. Here's a good star right here. I can put a star right there. If you had secondary adrenal insufficiency from, let's see, what's another cause of second adrenal insufficiency? How about a gene mutation for POMC, which is the precursor to ACTH? Yeah, how about that? Or how about a gene mutation to corticotropin-releasing hormone, CRH? That can also do it, right? It's rare, but it can happen as well. But the bottom line with secondary, the problem with secondary is you have decreased ACTH. So would our scenario still be working? So no. The R2A system would be able to stimulate, the angiotensin 2 would be able to bind to the cortex, adrenal cortex, and stimulate the zona glomerulosa and glomerulosa cells, because there's nothing wrong with it, right? That the adrenal gland is healthy in secondary adrenal insufficiency. Are we good with that? Blood loss, acute blood loss. Oh, this is just more. So therefore, these people are not they're not at risk for shock. Why do these conditions occur in Addison's disease? Acute adrenal crisis. Blood loss involved. What happened here? Oh, I think that slide was supposed to be back one. But anyway, so therefore, not only are the people at risk for hypoglycemia, I already said all this, they're at risk for hypovolemic shock and ventricular flutter or ventricular fibrillation because of the hyperkalemia. Kind of everything we talked about. So it's really easy for people to die from this condition if they're not treated. So what kicks off an adrenal crisis? What can do that? We kind of said severe stress, but what is a severe stress, according to Willis anyway? These are some common stressors that bring people into the ER because they are not secreting cortisol in response, and they're becoming hypoglycemic. And all the other things maybe. So septicemia is a very serious illness, right? You're in the hospital with that. Severe trauma, a car accident, broken femur, and you're bleeding internally, major crisis. Your adrenal gland's going to be secreting cortisol like crazy normally. If you can't secrete cortisol, you're in big trouble. Severe infection, burns can do it. Myocardial infarction can do it. Febrile illness. What's a febrile? What's that mean? Fever. Patient has fever, really sick. Like the coronavirus. Oh, thank you, Alexis. Sometime Alexa kind of goes, I don't know if you heard that or not. She goes crazy sometime. Strenuous activity. Yeah, that was kind of, that's not like going to work out at the gym. That's, maybe you get a flat tire out in the middle of nowhere and you fix the flat tire and it's hot and you're stressed and no one's going to rescue you. Your phone dies. That kind of stuff. And severe psychological stress. Not everybody, but some people severely affected by that. And that's probably enough to require the release of cortisol. I added that one myself because whatever reason Willis didn't include that, but there's sure evidence that shows that is the case. How about the diagnostic findings? Well, we really talked about all this, but here they go. For someone with primary and secondary, they can have hypoglycemia, so they have low blood sugar levels when they get tested. They have hyperkalemia. Now that's only for primary adrenal insufficiency, right? In secondary, there's nothing wrong with aldosterone release. Metabolic acidosis. So that's too much hydrogen ion. That's also only in secondary or only in primary, right? Because in secondary, your aldosterone would take care of that problem. Actually, let me add that to 338. I'm going to fix that one. Okay, and then hypotension and compensatory tachycardia from that. That's, again, only primary. That's only an aldosterone problem, right? Secondary, aldosterone still can work. Maybe not full power, but it can still work. Other findings, some exact findings. So how low is low? So serum cortisol levels of less than 4 micrograms per deciliter is worrisome. Normally it's at least 18. It should be above 18 cortisol levels all the time. And then there's those other vague symptoms again: nausea, abdominal pain, fever, confusion, malaise, and weakness. There are those vague findings which early in adrenal crisis can be very difficult to diagnose. So making the diagnosis, there's a couple of these tests. Now, the Williams and Jameson both said if your patient is critically ill, if he's in hypoglycemic shock with hardly any blood pressure, you don't mess around with these tests. You just give him cortisol and hydrocortisol and make sure they're okay. Hydrocortisone injection, make sure they're okay. But if you have time and they're not too bad, you can do a little testing. Right in the ER, you can do an acute ACTH stimulation test where you basically just give them a shot of ACTH and then see if they feel better. If they perk up all of a sudden, then you know it's probably secondary adrenal insufficiency, and you can treat accordingly. I mean, you don't have to worry anymore. They're coming out of that. Still got to worry about the cause. Maybe you look in the history and they were on prednisone for some kind of eczema, and they came off it, and there went their adrenal gland, didn't stop functioning. But if you give them a shot of ACTH and they don't feel better, and you do some blood work, and their cortisol levels are still in the toilet, very low, that probably indicates Addison's disease or primary adrenal insufficiency. And then you have to treat in a second. We'll show you what you do in a second. Now, if you in the lab, there's some other testing you can do. Since Addison's disease is usually caused by a 21-hydroxylase deficiency from an autoimmune attack, the body's going to have some antibodies against this. There's going to have antibodies around that attack the 21-hydroxylase. So you can test for those antibodies. You can also use a test called the corticosine synactin test, which is the gold standard. This is not going to be done in the ER, but you have to go in the lab, and it's way more complicated than this. But they basically do the same thing. They inject ACTH, and they see how your blood levels respond. They see how much glucose or how much cortisone is released in response to the ACTH, and they can tell how the function of your adrenal gland is by this test. Okay, but these are not done in the ER. What do you do? So what if they are critically ill? What's the first thing you do? I mean, chiropractors aren't going to do this, but medical docs, some may go on to work in the ER. You give them hydrocortisone. In fact, usually about 100 milligrams of it are put into their IV, and next 6 to 8 hours, that's what they get. Till you figure out, they'll give you some time to figure out, but you got to stabilize the patient right first. You can also give them blood glucose, and you can give them electrolytes, depending on what their blood chemistry looks like. But hydrocortisone is the key to survival. Okay, I think we know this. Primary versus, nice review slide here. Primary versus secondary adrenal insufficiency lab findings. So in primary, remember AKA for primary adrenal insufficiency is Addison's disease. They will have low levels, and just not walking around the street. They have to have a stressor, right, to cause this. But they will have low levels of cortisol. They'll have low levels of aldosterone, assuming that the stressor involves dehydration or blood loss. They'll have high levels. Here's the difference right here. They will have high levels of ACTH. I mean, if this has been going on for a long time, they'll also have skin change as well, right? They'll have pigmentation of the skin to go along with that high level ACTH. Secondary adrenal insufficiency, they will also have low levels of cortisol. They'll have normal levels of aldosterone because the zona glomerulosa, there's nothing wrong with that. That can still work if need be. But they'll have, here's the key, low levels of ACTH. So they won't have this extra skin hyperpigmentation. Okay, what's the treatment for once you're out of the ER and you're diagnosed with Addison's disease? Well, you always have to take hydrocortisone. Always. You don't have to take injections of it or intravenous, but you can go down to pills now. Now that the crisis is over, the stress is cured and you're back to normal. But you will have to take hydrocortisone levels. And interestingly, because some people say, well, do you have to take aldosterone as well? No, because remember that the cortisone can bind to MR receptors, right? Not the greatest in the world, but it can still bind. So therefore, just the hydrocortisone is enough it's like an aldosterone replacement as well. Okay, so that's all you have to take. You do not, I usually ask that question. I've asked that the last couple quarters, but no, you don't have to take a supplemental aldosterone. Hydrocortisone is good enough, right? So hint, hint. Often called glucocorticoid therapy. It increases blood sugar, increases blood volume because it stimulates the MR receptors as well. Decreases serum potassium, right? Because it acts like aldosterone, so it can stimulate that whole aldosterone chain of events, right? And there's not just hydrocortisone. There's dexamethasone, prednisone again could be used. Now, instead of 100 milligrams every 6 hours, you take 20 milligram tablet. And this is everybody's different, but an average is a 20 milligram tablet, and it's usually you take one in the morning, and you take not 20 milligrams daily. You take 10 in the morning, 5 in noon, 5 in early evening. But you may have to take more during the day, depending on what kind of stressors come at you during the day. Well, we haven't said a word about the zona reticularis and DHEA release. What about the adrenal androgens? They're not have anything to do with life. They're not going to kill you if you don't have those. But most in women, most of the DHEA does come from the adrenal gland. And if you have Addison's disease, or if you have secondary if you have either one of these, you're not going to be able to produce the DHEA, which is used to make testosterone, right? In fact, menopausal women, that's really the only source of testosterone, which you need for strong muscles and bones. It's important in that. They don't have as much as guys, but so they do have a deficiency. And it's interesting because they've done research on giving them a replacement testosterone and DHEA and DHEAS replacements. And the results, surprisingly, are mixed on this. Some people, their mood seems to increase. For whatever reason, there's no increase in osteoporosis or disease like that. And some people just feel better on it, but then some people don't even know they're on it. So it is controversial to replace the DHEA or not. Stress versus glucocorticoid therapy. We said stress demands, and I'm not talking a major accident and bleeding and things like that, but just the everyday stress that we encounter. So it will increase to smaller degrees the level of cortisol needed. It will soak up. Stress soaks up glucose. And this is a problem for people taking that 20 milligrams of hydrocortisone per day. It was 20, right? Yeah, 20 milligrams per day. It's a problem because maybe that's not going to be enough for them. So they have to learn, trial and error, how much they need. They might start getting hypoglycemic, and they will need to take another 5 milligrams or 10 milligrams. But here's kind of the rule of thumb from Jameson. Compensating for stressful events, or these are patients with Addison's disease more, but people with secondary as well might have to do this. But for a minor stress, like they fall down and small injury, or they just get the regular flu, they don't have a fever or anything, or they go to the dentist and now they have pain from the dentist, or big mental stress. Their kid gets suspended from school, something like that. That usually requires a doubling of the dose. So for the next few days, you still split it up 3 times a day, but you split 40 milligrams, so 20 in the morning, and then 10 in the afternoon, 10 at night. And that usually takes care of that until the stress settles down, and then you back down on it again. For major stress, if you get sick again, like a febrile illness or trauma, or you have surgery, you may have to take 10 to 20 times 200 milligrams per day, 400 milligrams per day. This is oral. You could go to the ER and they could inject it in there, put an IV. You wouldn't have to take as much, but you can still probably handle it with pills. All right. Again, we kind of said this already, but the biggest difference between primary versus secondary adrenal insufficiency is skin hyperpigmentation. And we already talked about that at the very beginning, but here it is again. Again, people with secondary hypoadrenalism or adrenal insufficiency, they can't make in people with Addison's disease, they don't make cortisol. So there's nothing to shut off ACTH, and they have very high levels of ACTH. ACTH gets in the skin, is converted to alpha MSH. Alpha MSH stimulates melanocytes in the stratum basale to inject the neighboring cells with too much melanin. The more melanin that's in one of your cells, the darker your skin's going to be. And that causes hyperpigmentation of the skin, which we said before, 94% of people with Addison's disease, they have this problem. What happens when the Addison's disease is corrected? What happens when you restore cortisol, even though you're doing it by tablet? What happens? Well, if you're taking cortisol of any kind, hydrocortisone or prednisone or whatever to correct the problem, it's going to activate the double negative feedback system. And therefore, your ACTH levels are going to go back to normal. And eventually, your skin is going to, probably in about a month, your skin's going to come back to normal color. So your tan is only temporary. There's a cute little melanocyte. This is the stratum basale here. Stratum corneum, the top of the skin, would be way up there. And so we can see ACTH stimulates too much ACTH in the bloodstream. It goes into gets into the dermis, right? This guy lives in stratum basale, so there's blood vessels here in the dermis. So ACTH gets in here, and it's converted to alpha MSH, and that stimulates the melanocyte to become hyperactive, and it secretes way too much melanin. Your nucleus is nice and protected, but your skin is starting to get quite dark because of this. All right, everything I said, patients with secondary adrenal insufficiency, they don't have bronze skin, right? Because they don't have high levels of ACTH. We said that a couple times already. Don't think I need to go through that. Hyperpigmentation, again, is usually patchy, not all the time. Sometimes it may not be even apparent on their body. What if it's a person of color? You won't be able to tell. But if you look at their gums and the mucous membranes, you'll see the patchiness there of a picture in a second. And it's commonly seen in mucous membranes. Sun exposure stimulates melanocytes anyway, so they get an extra boost. These creases, if you look at your palm and you see your lifeline, they don't look like somebody drew a marker on them. You can see them, but they're not like really dark. Palmar creases are, hyperpigmented palmar creases are quite common in this condition. The armpits, the nipples, so your knuckles, the elbow, friction points can become hyperpigmented. Okay, here's a patient with Addison's disease, and normally quite white in color. Here's her hands. Almost looks like African American here, although she's not. Here's before the disease. And, I mean, she would look like this. This isn't exactly the same patient, but she would look like she did before, after the disease. So you can see the skin color changes. Look how dark those palmar creases are, right? So that's a sign of Addison's disease, but not secondary insufficiency, adrenal insufficiency. There's another patient, bronzing the skin, secondary to Addison's disease. She did have the 21 hydroxylase antibody, so that was the cause of hers. Here is an example of someone's gums who has Addison's disease. This isn't disease, it's just hyperpigmentation. So it really does like to affect the mucous membranes. Don't forget to look there. All right, and there's just some hands that look bronzed, but there's no, I mean, she wears a ring, there's no, that was the point of this slide. That was after the treatment too, or a little bit after the treatment, how they're getting lighter. But they had a ring on, and just to prove it wasn't sunshine, you take the ring off. You know, if you take your ring off, you'll see a ring mark because it never gets any light, and there's no ring mark on her. That's the point of that one. All right, awesome. So now we're going to get into, actually we're not going to start that. I think that's enough for today, but now we're going to get into Cushing's disease, and we'll hit that one, which is really important, right? It's more common. We'll hit that one next week. All right, I will see you all later today, right? I owe you a double lecture on CVPP, so that's what we'll do next. See you later.